solidify everything. Okay. So first, before we start, I'm just going to share with you something that happened today. So a year from now, you're going to start to do clinical placements. And today I did my second day of my first clinical placement, so I'm very new to it. And we have basically a checklist of competencies we have to sign off on. So you'll have this as well. And there are things like taking blood from a vein, doing urinalysis, and they're all skills that we've only practiced like one time in clinical skills. And today I had to go up to a nurse and just say, please, can I attempt taking blood from a patient's vein? I went to this, this phlebotomist, and she was like, okay, go for it, try. And I looked at the patient and I realized, okay, this is like a 100-year-old lady. And I'd never even seen arms like that. It was really, really unfamiliar compared to the kind of plastic arms we use in clinical skills. And I tried to get this vein, and of course I failed because it was completely like, I couldn't even find it. And yeah, I walked away from that experience feeling like a complete idiot. And my point is that although year one, you're kind of a bit comfortable, you're just, behind a computer screen, and you can feel like, yeah, you're just learning from a textbook. Very soon, you're going to be in that same position where you have to basically make a complete fool of yourself and try and learn things in that context. So you should take every opportunity now to put yourself out of your comfort zone. And that can start today with this session, asking questions, being interactive, and trying to take every opportunity to learn, even if it makes you look like an idiot. So that's my message. So let's start. We're going to start with some questions on hormone cycles. So hopefully you can still see my screen, and you can log into this Pull Everywhere. Can everyone see that? This Pull Everywhere thing?
Yep. Yes, thank you.
Great. I have to activate it. Are people able to log in? And I haven't used this before. Can you log in and like put the questions?
Yeah.
Okay. Are people voting?
Chips are tasty.
Okay, we've got 21 results. How do I see them? Okay, well, that's good. You're 100% correct. Let's go to the next one. Okay. It's kind of funny. There's a consensus, and then all the outliers kind of move.
Pardon?
Okay. So, yes. So this is the correct answer over here. So most people have got it. So this thing here, that's kind of, it's called the interthalamic adhesion, and it doesn't really do anything. It's not a gland or anything. It's just, this is the thalamus. You've got two thalami, and there's this little thing that goes between and connects them. But yeah, this is the pineal gland under here. And you can locate it quite easily. If you see this big thing here, the corpus callosum, you go to the end of it here and just underneath. Maybe I can show you it. Yeah, so this is the splenium of the corpus callosum, and just below that is the pineal gland. Okay. I'm not going to show you what everyone's voting for, so you can all see if you're right at the end. Okay. Interesting. Okay, so 72% of you are wrong. The best description of melatonin secretion is diurnal. And I'll explain why in a minute. But circadian it's a bit right. So I understand why you've gone for that one. Wait, so I'll go and I'll explain this now. I'll go back to the slides. Let's go to pineal gland. Yeah, so this diagram shows this pathway. So we've got light hitting the retina. It goes via the suprachiasmatic and paraventricular nuclei of the hypothalamus. Hypothalamus is a really confusing area with loads of different nuclei. It's best not to even go into it at this point, I think, but just to remember these names and remember that they're in the hypothalamus, and that's enough. And okay, it goes through here. You'll learn about the superior cervical ganglion in your neuroblock. So again, don't get too bogged down. But the important thing is this little piece of the diagram. So you can see that here we've got an increase in the secretion of melatonin in the dark at night. When you feel sleepy, it's getting towards late, that's melatonin. And the reason it's not circadian, but it is a circadian rhythm because it has a 24-hour cycle. That's what circadian means. But the better description of it is diurnal, because diurnal means it's kind of a binary day-night cycle. So it's according to whether it's light and dark. Whereas a circadian can be anything that is according to a 24-hour clock. So for example, cortisol is at its highest just before you wake up. But it's not related to day and night. It's just related to that particular time of the 24-hour clock. So that's the difference between those two terms. Can anyone put in the chat any other examples of a circadian rhythm of a hormone? Something that's peaks at a particular time of the 24-hour clock. So yeah, cortisol, that's at its highest in the morning, yeah. Testosterone, can anyone put in the chat, when is testosterone at its most high? Yeah. So I don't know the exact time, but I think, yeah, it's kind of towards the very end of the day. Very good. Anything else? Who can name some hormones that have a monthly cycle? Okay, yeah, we've got LH, FSH. Any others? Progesterone, estrogen. Yeah, brilliant. So these have this monthly cycle, obviously. Estrogen, progesterone, FSH. Yeah, brilliant. Okay, so, and how about a pulsatile? Okay, so pulsatile is, so you can have a hormone that is secreted just at a constant level, and you can have a hormone that is secreted up and down, up and down, up and down throughout the day. And one that is pulsatile is GnRH. So yeah, exactly. So if GnRH is up and down, that's going to stimulate LH and FSH. Whereas if you had a GnRH given exogenously, so someone was taking GnRH, that's going to be a more constant level, and that's actually going to inhibit LH and FSH. So it's a bit confusing, but that's a good example of one that's pulsatile. Growth hormone, I'm not sure, to be honest. Might be. Yeah, testosterone as well. The testosterone is pulsatile because the GnRH is pulsatile. Yeah, but if you took GnRH in a constant level, then it would have a different effect. So yeah, interesting. Okay. Anyone have any other questions about that? Then put in the chat. Otherwise, we'll move on. Okay. Okay, we've got answers for this. Interesting. So which of these hormones stimulates the CAMP PKA pathway on binding to its receptor? So don't give in to peer pressure, guys, because it's actually not insulin. And it's not testosterone either. Yeah, okay, so I'll put you out of your misery. It's FSH. Okay, so FSH is a peptide hormone. Its receptor is on the surface membrane, and you'll find that all of the receptors that go via protein kinase A or protein kinase C, they are the peptide hormones. Insulin, testosterone, and vitamin D all have completely different mechanisms to exert their effects on cells, but we'll talk about that in a bit. We'll move on. So, which of these hormones has a receptor that dimerizes on activation? I'll give you a bit more time. Okay, yeah, correct. 68% of you are correct, is insulin. Okay. And which of these hormones has an intracellular receptor? Bravo, good. Okay, wait, we'll go back. So I'll talk about the receptors now. You have to remember insulin is a receptor tyrosine kinase. And as you all voted, it's dimerizing, that's the mechanism. So the insulin will bind to a receptor with another insulin, they will come together, and the intracellular tyrosine components activate when they come together. And that's how the signaling cascade then continues inside the cell. Whereas these hormones here, FSH, LH, ACTH, all these peptide hormones, and these hormones here, GnRH, oxytocin, ADH, all of these are going to go via either protein kinase A or protein kinase C. And the reason I'm showing you this weird slide is that these are the mnemonics that I found really useful to remember receptor types. And it seems overwhelming at the moment. There's a lot of them, but the idea of remembering each one individually is just too much. So I found it really useful to remember flat champ for the protein kinase A, goat hag for protein kinase C, piglet for the cytokine receptors. And so this might be useful for you. You might think it's overkill, it's up to you. Does anyone have any questions on those things? I think it's important to remember, so if you remember the signaling mechanism, you have something that binds to the peptide receptor, and if it's if there's the CAMP and protein kinase A pathway, and then there's the inositol triphosphate or diacyl glycerol that goes via protein kinase C. And they're like two distinct pathways, but the hormones that go via those pathways are usually peptide. And then insulin is a different case. And then, yeah. it seems a lot of information. I remember being quite overwhelmed when I first tried to learn it, but you kind of get used to it, I think, as you go forward. Okay. So next. So we're going to do some anatomy now. I'm going to take away this. Okay, that's perfect. Superior hypophyseal artery. Very good. And which of these directly precedes the inferior thyroid artery? This is quite a tough question. Okay, so we've got a kind of thinking about thyrocervical trunk and subclavian artery. So the clue in the question directly precedes. So you are right that the subclavian artery supplies the inferior thyroid artery, but it goes via the thyrocervical trunk. So it's actually C, but well done, because it's definitely not the other two. So where do the inferior thyroid veins drain? Interesting. I hope I haven't got it wrong, but it's the left brachiocephalic vein, actually. So I'll show you a diagram of that in a second, and we can try and remember it. What is the embryological tissue that gives rise to the thyroid gland? Okay. Good. Yes, endoderm is the correct answer. Okay, wait. Okay, we will move on. So I'll talk about the anatomy thing. So yeah, here we've got the, if you can remember this diagram, it's really useful. So we've got the anterior pituitary. I don't know if you can you see my cursor?
Yeah.
No. Yeah, great. Okay, so yeah, you've got the anterior pituitary, the blood supply from the superior thyroid is from the internal carotid artery. Okay, and this is going to supply, so what am I talking about? The superior, right? It's the anterior pituitary. It's going to go from the internal carotid artery. The blood's going to be bathed in hormones from the hypothalamus, and then this passes through these hypophyseal portal veins into this plexus here and stimulates. So for example, if we had GnRH coming from the hypothalamus, coming down here and then bathing the anterior pituitary in GnRH, this is then going to be stimulated to produce LH, FSH. And these are then going to be taken away. Then we have a completely different thing with the posterior pituitary. We don't need a blood supply from the hypothalamus to be bringing hormones, because we have, of course, the neurons directly producing them here. So this is the inferior hypophyseal artery. And there's definitely questions on this coming up, so it's good to remember it. Okay. So here we've got the thyrocervical trunk. The clue's in the name, so thyrocervical. This is an artery that gives rise to branches that supply the thyroid and other cervical structures. And it's coming off the right subclavian here and the left subclavian here. And this is, of course, the arch of the aorta. So if you want to trace it back to its root, it's the aorta, brachiocephalic trunk on the right side. On the left side, you've got the left subclavian directly from the aorta. Left subclavian then gives rise to the thyrocervical trunk, and then you've got the inferior thyroid artery. Important to remember as well with the thyroid, so you've got two arteries, a superior and inferior. Whereas when you look at the veins, you've got a superior, middle, and inferior. Okay. And as you can see with the veins, there's this asymmetry going on where both of the inferior thyroid veins are drawing into the left brachiocephalic vein. And yeah, is that clear for everyone? Hopefully it's clear. And it's just worth going between these images and just comparing and trying to get it into your head. Because they can easily ask a tricky question on this. And if you can't visualize it, it's very difficult. And yeah. So here we have the tracking from the foramen cecum. And I'm sure you've learned a bit about these cysts that can occur if the thyroid, if this passage doesn't fully close. And yeah, here you've got the thyroid gland. And yeah, you can easily remember it's endoderm, because if you learn the germ layers kind of in a big picture way, so the endoderm is generally stuff to do with the gastrointestinal tract from the mouth to the anus. So anything that comes off that, like liver, pancreas, foregut, midgut, hindgut, and even, yeah, at the posterior of the mouth, it's all going to be endoderm, whereas ectoderm is going to be the external structures, the skin. So that's one way to remember it. Okay, now let's go back to the quiz. So let's see what you come up with. Renin is good. Yep. Angiotensin 1 and 2, very good. Cortex, adrenal. ACTH. Calcium. Brilliant. Angiotensin is secreted by the kidney. Oh, angiotensinogen, sorry. See, I was going to remind you to read the questions properly, and that's a great way to demonstrate how easy it is to just read this as angiotensin, because it just looks the same if you're rushing. And I guarantee you will lose marks from just rushing through reading questions and getting straight to the answers. So just force yourself to reread it and really look at the letters. So yeah, angiotensinogen is not secreted by the kidney, it's secreted by the liver. And so, yeah, let's go. I can't see the chat again. Wait, can I? Can anyone tell me what is secreted by the kidney in this axis? Yes. And can anyone tell me which cells secrete renin? Yeah, juxta something. Juxta what? Juxtaglomerular. Very good. So that just means it's next to the glomerulus, and that's strategic because these cells have to sense certain things. Can anyone tell me what kind of cells they are, the juxtaglomerular cells? This is a really tricky one. Like, are they epithelial cells? Are they nerve cells? Are they muscle cells? No. So they are actually muscle. They are muscle cells that have the ability to sense pressure, which is called a baroreceptor. So they are baroreceptors, these cells, and they can sense pressure. And that's important because renin is secreted in response to low pressure. So we'll talk about that more in a second. See if we've got any more questions on this. Yeah, so I hope I haven't just answered my own question. Regulate blood pressure, maintain blood pressure, increase blood volume, increase blood pressure. Reduce blood pressure, interesting. Yeah, so this, I love this kind of question because you can all like vote for each other's stuff and like battle it out with your different answers. So raised blood pressure has got a lot of votes. I approve of this. This is good. You've all been very nice. You have, okay, we've got one person who has a -1. I don't know why. I thought that was okay. Okay. Well, this is great. So I'm going to give this a star. Wait, can I give it a star? Okay. So the answer is correct. Well done. Okay, wait. Okay, we'll go back. So let's talk about ROS, renin, angiotensin, aldosterone system. So let me see the chart. Okay, so yeah, this is the system. And basically, I wanted to just highlight that the endocrine system, everything is about homeostasis. It's very logical. So when you see what things are input to make renin secreted by these juxtaglomerular cells, it's low sodium, it's hypovolemia, hypotension. And what comes out at the end? Oh, interesting. It's increased blood pressure, it's increased volume, and it's increased sodium is the mechanism by which the body increases the volume because the water follows the sodium. So the input is opposite to the output, and that is negative feedback. That is the point of the endocrine system, really. So if you can remember the things that stimulate the ROS system, then you can basically work out the rest of it. And that would be my point. Remember, what is the point of this thing? What stimulates it? What's coming out at the other end? And then you can much more easily remember the details between the beginning and the end. So yeah, we've got renin, angiotensin, Can you remember where ACE does its thing? Yeah, very good. And when we say central, does anyone know exactly where angiotensin 2 exerts its effects centrally? When we say central, we mean the central nervous system. Can anyone remember where in the brain? Angiotensin 2. Yes, very good. Very good. Hypothalamus. It's going to make you thirsty, going to make you want crisps, and that is so that you're going to be able to retain more fluid because water follows that sodium. And this is a nice diagram as well because it illustrates that angiotensin 2 is not just there to stimulate aldosterone release. It has its own huge array of effects, all of its own. Okay, and then aldosterone, its main thing is to decrease potassium. So it's going to secrete the potassium in the distal convoluted tubule. And I don't know if you've learned about that stuff yet, so I'm not going to go into it. Okay. So now we're going to talk about diabetes. So which cells produce insulin? 100%. Very good. Can anyone tell me which hormone is produced by the alpha cells? Yes. Can anyone tell me what kind of hormone is glucagon? Yes, it's a peptide hormone. Very good. Can anyone tell me what hormone is produced by the delta cells? Perfect. And what's the point of somatostatin? What does it do? These are all good answers. Somatostatin inhibition. Inhibition is my favorite answer so far, Katie, because somatostatin basically is a universal hormone inhibitor. So yes, it inhibits insulin and glucagon, but it also inhibits gastrin in the stomach. It inhibits all kinds of stuff. Wherever it is, it just tells the other glands to be quiet. And that's the point of somatostatin. So very good. But yes, you can say that in the hypothalamic pituitary axis, its main target is growth hormone. That would be correct as well. The islets of Langerhans is okay. It is a tissue. It's basically just groups of cells in the pancreas. Yeah. Interestingly, so if you look at the islets of Langerhans, there's a certain arrangement of the cells. So you have the beta cells are kind of in the middle of a little circle of alpha cells, and the delta cells are kind of randomly spread out. And this is useful because you have the insulin being produced by the beta cells kind of washing out and bathing all of the alpha cells in insulin. And insulin actually inhibits the secretion of glucagon by those alpha cells. So yeah, there's a certain arrangement to it. What's the best description of insulin? Is it the only hormone that lowers blood glucose, only hormone that raises blood glucose, one of the many hormones that raises blood glucose, one of the many hormones that lowers blood glucose? Interesting. Okay. So it's actually the only hormone in the body that lowers blood glucose. And you can remember this because people who have insulin deficiency, people with diabetes, they don't have any other deficiencies, but their blood regulation is completely destroyed. If they have an absolute insulin deficiency, they cannot regulate their blood glucose. So people who don't have any glucagon, if that's a thing, we don't really know if it's a thing because we don't hear about it, because there are loads of hormones that can actually raise your blood glucose. There's glucagon, there's also cortisol, there's also growth hormone. So these groups of hormones that raise your blood glucose in times of stress, in times of inflammation, are called counter-regulatory hormones. But insulin is the only one that can lower your blood glucose. We've got a question. Do thyroid hormones affect blood glucose? Yeah, I think thyroid hormone is another one of these counter-regulatory hormones that raises your blood glucose. So yeah, interesting. Next one. Which type of diabetes is most associated with HLA, DR3, and DR4 genotype? Okay, so that is correct. It is type 1. And in prediabetes, type 2, how are insulin levels best described? I'm really impressed. This is good. And in which of these describes the mechanism behind diabetes type 1? Brilliant. 100% of you are correct. Okay, wait, we'll go back. I can't keep track of my own questions. Okay, so diabetes type 1 and 2. So I thought, because this is quite confusing, I certainly found it hard to remember. I've just made like a summary. So type 1, remember the buzzwords: genetic, autoimmune. Also, you can think of it as it always happens, almost always during childhood, because it's a genetic thing, okay? And it starts with these autoantibodies against the insulin-producing beta cells, okay? And these beta cells are destroyed. And as a result, you've got an absolute insulin deficiency with fasting hypoglycemia, okay? So that's like when you haven't even eaten glucose, you've still got hypoglycemia because the cells just cannot take up that glucose. They just haven't got those transporters in their membrane. Okay. Whereas type 2 is much more environmental, multifactorial, can't narrow it down easily to particular genes in the same way as you can with type 1. And we've got obesity, insulin resistance. The obesity causes the peripheral insulin resistance, because you've got lipids in your blood that have this effect on the insulin receptor. I think it's not very well understood, but just remember obesity. You've got insulin resistance, which means the beta cells have to work much harder to produce enough insulin to have the desired effect of taking up that glucose into the cells. And this, of course, initially you have lots of insulin, but this can't continue. So you've got these amylin deposits because amylin is produced alongside insulin in a 1-to-1 ratio. So the more insulin you have, the more amylin you have. Then yeah, so the first effects will be isolated postprandial hypoglycemia. So you just eat and it goes way too high, but then you manage to get it back under control. But late diabetes type 2, if it's not well controlled, you're going to get the fasting hypoglycemia, just like in type 1. So they have the same end result if they're not well controlled. And here's just a diagram to illustrate this. So you've got the post-meal glucose. So you've got, yeah, so the first thing is this purple line here. So this is like the trigger of it all, which is the insulin resistance. And as a response, this green line here is the insulin level. Initially, the insulin level tracks the same path as the insulin resistance. It keeps up. So the more insulin resistance you have, the more insulin you have. But then this red line is the beta cell function. And as this red line goes down, you can see the insulin levels going down. And that's when you have this fasting glucose level creeping up and up and up. And as a result of that, you've got these macrovascular, microvascular complications. And that's something you'll learn about next year, probably, yeah. So I'll just check if any questions on that. Will these slides be shared with us? Yeah, of course. I'm not sure how, but I will make sure they're shared with you. Okay. Next question. Which hormone is essential to the CNS maturation in early infancy? Okay. So the correct answer is thyroid hormone. Now, I don't know if, I'm sure growth hormone, and I'm not sure about testosterone. I think testosterone is important for the creating a male brain during fetal life. So the male fetus needs testosterone in order to create a brain that is male. But testosterone levels are actually very, very low in newborn boys. I think testosterone levels only go up again. So there's high testosterone early on in fetal life in order to have the external genitalia and the internal genitalia mature. But then it's very, very low until adolescence. Growth hormone and thyroid hormone, probably both of them are important, but in particular, thyroid hormone. And we know this because some cases where children have a thyroid hormone deficiency, or where they are so malnourished that they don't have enough iodine in their diet to produce thyroid hormone, you have a condition called cretinism, which is basically these children have permanent learning difficulties as a result of having thyroid hormone deficiency. So that's how you know that thyroid hormone must be very, very important in this early fetal life. Interestingly, the placenta actually delivers a fetus thyroid hormone. And so in the first few months of a newborn life, even if there's thyroid deficiency in the diet or they have a congenital defect, that means they can't produce thyroid hormone. Because thyroid hormone is stored in the thyroid gland in this colloid, this iodine is stored. The effects of the deficiency only happens quite a long time after they've been born. So within the first year of life, but not straight away, because they've got this store. And this is a recurrent theme you'll see in things like other deficiency diseases. They tend not to happen straight away because they've got some kind of store. It might be in the liver if you're talking about copper or iron. But it's the same with thyroid hormone. So that's important for CNS maturation. Next question. Fill in the blank. Very good. No, it's not ACTH. Great, I think that's good. That's fine. True or false? T3 has a longer half-life than T4. Okay. And the thyroid hormone receptor has a higher affinity for T3 than T4. True or false? So interesting. So this is correct. So true, the thyroid hormone receptor does have higher affinity for T3 than T4. And then the question before, I didn't want to give it away, but okay, so this is, most of you are wrong actually. So T3 has a shorter half-life than T4. T4 lasts longer. So let's look at the slide for this. So can anyone tell me what they think affinity means? So I say that the receptor has a higher affinity for T3 than T4. What does that mean? Exactly. Yeah. Look, AM, that's good. So exactly. So if there's T3 around, you can imagine if you have a certain number of receptors, a certain number of molecules of T3, it's going to have a stronger effect on the cell than if those molecules were T4. That's how I understand it. There might be KM involved. I'm not sure, probably. But with the half-lives, T3 has a much shorter half-life. So it's more potent, but it's also much quicker to dissipate in the body. T3 has a half-life of, I think, 24 hours. So after 24 hours, half of it is not detectable. It's already been metabolized. Whereas T4 has a half-life of about a week. So which one do you think, if you had someone with hypothyroidism, which of these two would you want to give to the patient exogenously? Which would you give as a medication? Would you want the one that has the most potent effect or the longest half-life? Yeah, you'd give T4 because you want them to have a stable level of thyroid hormone. You don't want a sudden surge and then back down to nothing. You want a nice stable amount. So you'd give T4, exactly. Good. And can anyone name some effects of thyroid hormone in the body? Apart from CNS, we talked about CNS. So it stimulates your neurons to grow and to synapse with each other, which is important. Thermogenesis, metabolism. Yes. And can anyone tell me some symptoms of if you had excess thyroid hormone in your body, hypothyroidism? Mm-hmm. Yes. Okay, so we've got palpitations, very good. Tachycardia. How about heat? So does someone with hypothyroidism, are they okay being in a, yeah, heat intolerance, exactly. So they go in a normal room and they'll be really hot because thyroid hormone is stimulating their beta-3 receptors in their brown fat to produce lots of heat. And yeah. Exactly, high metabolic rate. Everything's going faster. How about hypothyroidism? Has anyone got any ideas about that? What symptoms you'd look out for? I think you mean bradycardia. Yeah, slow movement, fatigue, cold intolerance. Wow, yeah, this is really good. How about facially? What would there be any features on their face that you'd look out for? I think moon-faced is Cushing's, which is excess cortisol, but there's some overlap. I totally agree. There's a kind of puffiness that is with this hypothyroidism, which is also seen in Cushing's. Yeah, so goiter is interesting. Can anyone tell me what goiter is? Thyroid swelling, exactly. And exophthalmos, so bulging eyes, that's actually seen in, I think, Graves' disease, which is hyperthyroidism. Whereas hypothyroidism, you'd have something called ptosis, which is where your eyelids are kind of droopy. And so that's kind of interesting. The exophthalmos in Graves' disease is because you've got inflammation behind the eyes, and you've got like deposition of fat and stuff going on there because of the autoimmune inflammation that's going on in the body. And so their eyes are kind of pushed outwards and look very alert because of that. Yeah, okay. So which hormones are important in regulating calcium and phosphate levels? Calcitonin, PTH, parathyroid hormone. How about any vitamins? There we go, yeah. Vitamin D, brilliant. Which of these stimulates 1-alpha hydroxylase enzyme? Calcium, PTH, vitamin D, phosphate. Stimulates. Which of them stimulates it? Okay. So the answer is B, parathyroid hormone. The others are all involved, but they actually inhibit it. Okay. Vitamin D levels are controlled by regulation of which enzyme? Very good. This is a really confusing question. It's tricky, but your majority of you are right. It's 25 hydroxylase. And what are the effects of parathyroid hormone? I'm not going to give you more time. So you're wrong. It increases phosphate secretion by the kidney. So reabsorption is getting it back, pulling it back into the body. Secretion is getting rid of it into the urine, okay? And there is a really, really easy way to remember this, which I want you to remember forever, okay? And you can always remember that I was the one to tell you. PTH stands for parathyroid hormone, but it also stands for phosphate trashing hormone, okay? This hormone hates phosphate, puts it in the trash, puts it in your urine, gets rid of it, okay? But parathyroid hormone loves calcium, and everything parathyroid hormone does is in order to increase the free calcium in your blood. So it stimulates absorption of bone into the blood. So releases that calcium from the bones. But the important thing is when it releases calcium from the bones, it's also going to release phosphate because bones are made of calcium phosphate. So that calcium and that phosphate is going to bind to each other. And so the free calcium is not going to be increased. So that's why parathyroid hormone has to also get rid of phosphate selectively and retain the calcium in order to increase the free calcium. And if there's low free calcium in the blood, that's what stimulates the parathyroid glands to produce parathyroid hormone. And if there's high phosphate, again, that's going to stimulate the parathyroid glands as well. So just remember phosphate trashing hormone and the rest of it will take care of itself. Okay. And phosphate trashing hormone secretion is increased by what? I think I just told you this. Let's see if you listened. So there's two correct answers, so you don't have to second guess yourself. It's hypocalcemia and hyperphosphatemia. And the others, a hypercalcemia would inhibit, and high levels of vitamin D would also inhibit PTH. Okay, I'll quickly, because we are coming up to 7, so I don't want to hold you here for too much longer. I'll quickly just talk about this for a second. So here's a summary of the mineral homeostasis. And I think it's worth having an idea of what each hormone wants to do. Parathyroid hormone, its main ambition is to increase the calcium, the free calcium in the blood. Whereas vitamin D or calcitriol, its main ambition is to increase the mineralization of bones. So it wants there to be more calcium and more phosphate reabsorption from both the gut and the kidney. It wants these to be high in the blood so that the bone, the cells, the osteocytes, the osteoblasts, sorry, can effectively mineralize the bone. PTH doesn't care about the bone, it just wants there to be more calcium in the blood. And then calcitonin, I remember this, bone in, it wants to put both calcium and phosphate in the bone. And its main ambition is not really about the bones or anything, but it's just to decrease the amount of calcium and phosphate in the blood. So it wants to pack everything away, whether it's into the urine, it doesn't want to absorb it from the GI tract. It puts it in the bones because it wants the blood to be clear of calcium and phosphate. And if you can remember that, you can remember what's the point of each one of these, then it's very intuitive what it's going to do in the gut, in the bone, and kidney. Yeah. And then this is just a summary of the effects in this axis. So again, it's intuitive. So whatever is going to be produced by 1-alpha-hydroxylase, so this is going to turn 25-hydroxycholcalciferol into vitamin D. So if it's producing vitamin D is going to inhibit its action because it's negative feedback. We see this in every endocrine system. Okay, so the first thing that's going to inhibit 1-alpha-hydroxylase is vitamin D. Then also because vitamin D increases the amount of calcium and phosphate in the blood, that those things are also going to inhibit 1-alpha hydroxylase enzyme. And then there's this weird thing, FGF23. I don't know what that is, to be honest, but for some reason, they really like you to know that this thing also inhibits 1-alpha hydroxylase. So if you just learn that, you never know, it might come up. From my experience, it is something that tends to, so worth just remembering that. And then of course, parathyroid hormone, which is secreted by the parathyroid glands in response to low calcium, wants to increase the amount of vitamin D in the blood, because vitamin D allows the absorption of calcium from the gut. So that's going to increase the activity of 1-alpha hydroxylase so that there's more vitamin D around to do that. And this is just this horrible rank L stuff. So PTH, vitamin D, these are both going to act on these osteoblasts. And those osteoblasts have a job of producing rank L to stimulate osteoclasts to release calcium and phosphate into the blood. So yeah, I hope that's useful. I think that's everything. So if anyone has any questions at all, now is your time. And otherwise, it would be really amazing. I would really appreciate it if you can give me some feedback, and for the peer medics guys as well, it really helps them. But that's the end. I hope I didn't say too much.
Thank you very much.
It's an absolute pleasure, guys. Thank you for being so responsive.